Good morning. Whoa, you make me sad. Let's try that again. Good morning. Now we're talking. On behalf of Family Medicine for America's Health, I welcome you as Health is Primary comes to Chicago, Illinois. So my name is Jerry Cruz. I am a family physician. I come to you from Southern Illinois University, where I am the Executive Associate Dean for the SIU School of Medicine and the CEO of SIU Healthcare, our multi-specialty group practice. I bring you greetings as the Society of Teachers of Family Medicine's representative to Family Medicine for America's Health. Health is primary. So I think we all know that there's great change occurring in medicine today, change that's sorely needed, change that's unrelenting for sure. And with change like that comes the opportunity to meet the objectives of health is primary. And those are the triple aim, effectiveness, efficiency, and equity in healthcare. So just a word about equity. That's universal access to the best patient care experience or the best healthcare experience. And there is no doubt that increasing access to primary care is the best way to improve healthcare equity and to reduce health outcome disparities. At the macro level, the national level right now, we have tools that help us with these objectives. The ACA, the Medicare Access and CHIP Reauthorization Act, they move us toward universal access, they move us toward healthcare payment reform, and those things are important, but they're not the most important things. The most important tools that we have very clearly are our relationships that we have with our patients, with our families, with our communities, and with our colleagues in other healthcare disciplines. So today, you're going to hear some stories that show some success and engagement with patients, families, and communities. And those stories will be the foundation for broader policies and broader programs that bring better healthcare education, better healthcare, and better health to our state and to our nation. Now, you can't come to a meeting in Illinois without hearing a quote from Abraham Lincoln, right? He said, "Things come to those who wait, but only things left by those who hustle." So times are a-wasting. It's time to hustle, and we're going to show you how we do it today. So we'll thank you very much for coming, and next to the podium will be Dr. Alicia Martin, who is the president of the Illinois Osteopathic Medical Society.
Thank you. As he said, my name is Alicia Martin. I am also a family physician. I work with DuPage Medical Group in the western suburbs in Naperville. I'm here really as two roles. First as the president of the Illinois Osteopathic Medical Society, and second as a member of the ACUFP. ACUFP is the American College of Osteopathic Family Physicians. We have way too many acronyms here in medicine, but ACUFP has been a partner in this initiative, and we're very excited to bring this to Chicago and to the state of Illinois. Osteopathic medicine traditionally has been brought out to the community, so I think we're a great partner to continue this program here. Thank you for everyone for attending.
Well, let me add my good morning. And just to talk a little bit about how family doctors work, Dr. Martin failed to mention that her father is actually a member of our board for Family Medicine for America's Health, so that's how family medicine rolls. So we're excited to be here today on our tour of communities around the country, communities where primary care and family medicine are making health primary. Our campaign, Health is Primary, is collecting and sharing stories of innovation that are driving the future of healthcare in America, and you'll hear just a sample today of the exciting things happening in Chicago and around Illinois from our speakers today. First, I have to ask, family physicians in the audience, raise your hand. Happy World Family Doctor Day. So, not quite a Hallmark holiday yet, but May 19th is World Family Doctor Day, and it'll be a Hallmark holiday someday. So I'm Glenn Stream. I'm a family physician practicing in La Quinta, California, and I'm the president and board chair for Family Medicine for America's Health, a newly established coalition of 8 national family medicine organizations, of which you've already heard about, ACOFP and Society of Teachers of Family Medicine. So these groups represent all aspects of family medicine, practicing family physicians, folks involved in research, and people involved in academic medicine and training our current and future physician workforce. Family Medicine for America's Health has come together with one mission, and that's to improve health in America. As everyone knows, our nation is facing a health crisis. We have the most expensive healthcare system in the world, and yet the citizens of our country don't enjoy the good health that they should. It's time to put the health back in healthcare. We believe that the solution to many of our problems is primary care. And we're so convinced of it, we built the Health is Primary campaign to make the case to patients, payers, and policymakers that a strong primary care system will allow us to deliver on the promise of the triple aim: better health care, better health for our people, and really addressing the serious cost crisis in our healthcare system. The evidence that primary care is strong and speaks for itself. We know that access to primary care helps us live longer, healthier lives. In areas of the country where there are more primary care providers per population, death rates for cancer, heart disease, and stroke are lower, and people are less likely to be hospitalized. An increase of 1 family physician per 10,000 population can decrease costly and unnecessary care. Outpatient visits decline by 5%. Inpatient admissions by 5.5%, surgeries even decline by 7.2%. Evidence shows that primary care is associated with a more equitable distribution of health in populations. U.S. adults who have a primary care physician have 33% lower global health care costs. Medicare spending is lower for states that have more primary care physicians, and these states have a more effective and high-quality care for their people. Health, quality, and cost. That's the triple aim we must achieve, and we believe primary care is best positioned to deliver that. I'd like to share a brief video.
When we were growing up, medicine meant our family doctor. When we were sick, had a broken bone, or got hurt, that's where we went. The technology was simpler then, but our doctors took care of us and helped us stay healthy. Things changed over time. We changed, and healthcare started to change too. Scientific advancements made medicines and treatment better, but the healthcare system got more complicated. We started spending a lot more money, but all that investment didn't make people healthier. Healthcare started to feel a little disjointed and impersonal. Now everybody is talking about reform and the system. It's gotten pretty loud, but nobody's really talking about health. Good health. Isn't that really what we all want? Our country has the best doctors, the best hospitals, and the most innovative scientists. Shouldn't we be healthy? Somewhere we lost our way. We forgot what matters. We need to embrace the values that make people healthy, like a long-term relationship with a trusted doctor, someone who knows us, our family, and our risk factors, someone we can connect with when we need them, who uses the latest technology, someone who can help us stay healthy, and when we're sick, help us get the most from the healthcare system, someone who can see the big picture and the small one. That's what the best healthcare should be, a system based on primary care that can make our advanced medical system work for real people. We know how to get there, and going there now can give us a system that works for everyone and makes us healthy again. Now is the time. Together, let's make America a place where health is primary.
So what does healthcare look like in America when health is primary? We believe it looks a lot like family medicine. And we want to work to ensure, whether your primary care provider is a family physician or not, that you live in a place where health is primary. A place where doctors and patients work together in true partnership, where doctors have long-term relationships with their patients and see and treat the whole person and the whole family, where technology supports and fosters the connection between patients and doctors, where everyone has access to a medical home where most, if not all, of their health care needs can be met, and a coordinated medical neighborhood when additional care is needed. Where prevention and health promotion are as important as treating disease. Where doctors work with community leaders to address individual and population health. Where health disparities are reduced by increasing access to good primary care. And where financial incentives align with promoting that good primary care. Today, you'll hear from our panelists about their practices and their work to ensure a solid primary care workforce here in Illinois. Their conversation today will focus on different aspects of their work and innovations that are helping them drive results for patients and communities across the state. While these stories may seem different, there's a common theme. They all focus on delivering continuous, comprehensive, coordinated, and compassionate care, the model of primary care we believe and know can transform the healthcare system in America. Ensuring a strong foundation of primary care is what's going to make us healthy again. In addition to our work to spread the word about how primary care is delivering better care and better health at lower cost, we want to do the work that's necessary to take it to scale and accelerate the pace of reform. That's why, in lockstep with our work on health as primary, we're working with other primary care groups, payers, and policymakers to enhance and modernize the primary care system in America. We will be forming multidisciplinary teams to expand access to the patient-centered medical home advanced model of primary care, to improve the use of technology and practice efficiency in patient care, to recruit the best and brightest to primary care workforce, and to shift to a comprehensive primary care payment system that rewards and incents that system. It won't happen overnight, and we can't do it alone. We're inviting our colleagues in healthcare, payers, employers, patients, and the broader medical community to join us in this cause. And we are collecting and sharing models of innovation like those here today that are going to help make America a place where health is primary, and that's what today's session is all about. So I'd like to introduce our moderator for the morning session, someone who's seen firsthand the ironclad rule that primary care is the foundation of the health systems around the world that deliver good care for patients and communities. T.R. Reid has become one of the best-known reporters through his books and articles, documentary films, for his reporting for the Washington Post and commentaries on NPR's Morning Edition. Tom has written 9 books in English, 3 in Japanese, and translated one from Japanese to English. He understands healthcare. His 2009 book, The Healing of America, A Survey of Healthcare Systems and Innovation Around the World, became a national bestseller. And his film, U.S. Healthcare, The Good News, highlighted stories about the parts of our system that are working. And this is what we're trying to do with Health is Primary, and he's here to help us tell that story about primary care and family medicine efforts here in this state. So I'd like to turn it over to Tom to lead our panel discussion about the great stories from here in Chicago and Illinois. Thank you very much.
Thanks, Glenn. Hi, everybody. I just want to say, for a boy from Colorado, it is always thrilling to come to Chicago. I mean, the energy in the city is, we just don't, you know, the late lamented Marshall Fields used to say there's nothing like it back home. And I really feel that's true when I come to Chicago. The excitement in the city and the architecture is just phenomenal. And you know, I'm from Colorado, and we're very proud of our mountain scenery in Colorado. As I think you know, we're the highest state in the nation in more ways than one. But we really don't have any great thriving city with architecture like Chicago does. And this goes back a long way here. As you know, Louis Sullivan and Chicago builders invented the skyscraper. It started here, and God, look what you have now. It's really phenomenal. And it's kind of fitting that we're talking about healthcare because, in addition, Chicago and the whole state of Illinois have been big innovators in healthcare, and particularly in healthcare delivery, and trying to find ways to get more care for people, to get more Americans the health care they need at lower costs. It's hard to do, but what we're going to hear today are some really striking cases of doctors doing this. And the kind of common theme we're going to find here is, in each case, this is led by a doctor in primary care docs, which doesn't surprise me much because, as Glenn said, I went around the world and looked at healthcare systems. As I'm sure you know, all the other countries like us, I mean by that advanced, high-tech, free market democracies, there are about 35 of them on the planet. All of them provide health care for everybody of high quality. And on average, they spend half as much as we do. There's only one industrialized democracy that doesn't cover everybody, and that's the world's richest country, the USA. We've got to fix that, and I think this emphasis on primary care is a key part of doing it, because when I went around the world, health ministers, economists, doctors, they all told me that they thought the proper ratio of primary care to specialist was in the range of 60% primary care, 40% specialist, or even higher. Britain is about 64% primary care. They have better health outcomes than we do. They cover everybody for half as much. I think there's a connection there. And of course, the United States is upside down. We're at what, Glenn, 32% primary care, and those expensive specialists are the majority. These things go together because, as Glenn said, there's an ironclad rule. If you put a focus on primary care delivery, you're going to get better health outcomes at lower costs. This is true in all the countries, and it's a key reason that upside-down status is a key reason why the United States is paying more for health care and getting less than all the other rich countries. So we're going to talk today about some just amazing stuff that's going on in Chicago and Illinois in healthcare, driven primarily by primary care docs. And we're going to do this in two panels today. First of all, we're going to look at new means of delivery, new methods of healthcare delivery. Shortly, we're going to meet a doctor who told me he hasn't seen a patient in his office in 20 years, but he's practicing. That really blew me away. And then after a short break, we're going to talk about team approaches to healthcare, which Illinois is really a leader in this area. It's important, it's working, and it's going to be interesting to hear. So what I want to do now is just start off our first panel, and like each of our panelists, just to introduce yourselves and tell us who you are and what you're doing.
My name is Dr. Tom Cornwell. I'm the one that hasn't been in the office for the last 20 years. I've done over 31,000 house calls, and so that is where my office is. And in 1997, Northwestern Central DuPage Hospital was kind enough to agree to support the program after my children's pastor wife had been supporting the program financially for us, and that wasn't very scalable. I realize now, but our mission of house calls is to help homebound patients, to help caregivers, and reduce healthcare costs. And it's the latter that is getting so much attention in the country right now. 2 years ago, I also received a large philanthropic gift, where now what I'm doing is just trying to spread house call programs, mostly in Chicago, but also across the country. I see John Hickner in the back, and we're working with UIC as one of the programs. So I'm excited to be here, excited to be a family physician.
Hi, good morning. I'm Opella Ernest, Dr. Opella Ernest. I'm the Chief Medical Officer for Blue Cross Blue Shield of Illinois. And recently, I've also assumed responsibility for our network. So we are now called Healthcare Delivery, and that's an important to me in particular because that just really reflects the direction of how we see it. And so when you think about what we do and what our focus is and what my focus is, it is how do we transfer from fee-for-service to value, and how do we help docs do that? So as a family practitioner, that's particularly important to me, and we've done that, and you will talk about that with some of our models from our accountable care agreements, which many of you have heard about. Our intensive medical home is another model. But one of the models that I'm really interested in right now is how do we develop models and ways for physicians who are smaller, from anywhere from 2 to 5 and above, may not necessarily be affiliated with a particular system, but they still want to move from fee-for-service to value. So that's an area of interest for us right now as well.
Good morning. My name is Javette Orgain. I'm a family physician, and I currently serve as the director of the Illinois Department, as the chair of the Illinois State Board of Health, which advises the director of the Illinois Department of Public Health. So family physicians are everywhere in terms of what we do. I'm also a clinical associate professor of family medicine at University of Illinois, Department of Family Medicine. I serve as the vice speaker for the American Academy of Family Physicians, and I'm here today to talk about end-of-life care as a hospital.
Ouch. Ouch. That's powerful, Javette.
Yes. All right.
What do you think?
Thank you.
Okay.
So I'm here today to talk about end-of-life care as a hospice physician for VITAS Healthcare. We, as family physicians, see patients from birth to end of life with compassionate care, as has been described. And as part of what we do, we encourage families and patients to consider. We also need a change in the culture in regards to death and dying in America. And so I'm glad to see you all here so that we can have that discussion as well. Thank you.
Thanks. So I'm intrigued, Dr. Ernest, we're working to replace fee-for-service with value. So I have two questions. What does it mean, and how do you do it?
Sure. So in the current system that we all, can you guys hear me okay? In the current system that we all trained in, as we know, fee-for-service is basically where you bill for every service that you deliver as a physician. And our goal is to transfer from that model to what we call value-based care. And how do we do that? We try to create models that incentivize our physicians and our providers of care to deliver the care and focus primarily on a total, more comprehensive experience for the member and for the patient, and to hopefully to get to the triple aim. So to do that, we've done a couple things already. We've actually been Blue Cross Blue Shield we've been here for over 77 plus years. We have certainly had incentive models for our providers of care over the years, but I think what's different, of course, with the Affordable Care Act, we have really put a stake in the ground about making that progression. And so one of the models that you'll hear about is our intensive medical home, and I see a couple familiar faces here, and they've heard about that. And our intensive medical home is primarily where we focus on the higher risk. We, meaning we allow the providers, because we can't practice, so everything we do is to enable you. And so we actually pay for a resource to be in the physician's office, and that physician determines how that resource is utilized. But the model is really designed for that nurse to focus on a specific population of members in that practice. So, that's one model that we talk about. The second, of course, is the accountable care organizations. And you've heard about our agreement with Advocate. Many of you have. Very large. It's now 2011. So can you imagine now that we're already in the second phase of another agreement? So we've started the ACO piece. We now have over 9 ACOs with over 450,000 members, and those are accountable care organizations. And what makes it unique is that the ACOs are not, these are PPO, so when you have a PPO, you can go anywhere. These are members that are in a PPO, so they can go anywhere that they want to go. But we have preferred provider organizations, so it's a broad, you told me you'd ask about acronyms, PPO. And so these are patients who are not required to go to any physician. They are not required to be in a coordinated care model, but the physicians have agreed to say, hey, we think these are our groups of patients. We help provide the analytics, and then they provide care, and together we work together to support the triple aim. Very interesting. We've had nothing but excitement around it.
How do you set a price?
It's a discussion. And so I think that's really what's important about it. It's a collaboration, it's a discussion. Probably the biggest part, though, is really how do you decide who's your patient? Because if you're in you have to.
This isn't obvious?
It isn't, because you don't have to pick a PCP. So the difference is, if you think about an HMO, if you don't use the term a health maintenance organization, the HMO is actually the model that if you didn't describe it and call it an HMO, it's one of the very early coordinated care models. I mean, it has everything in it. It has the perfect attribution. You pick a physician, perfect model, right, in terms of if you described it and took away the word, because all of us have, not all of us, some of us have residual reactions, feelings about the word. But if you think about what the model is, that's the model. In a PPO, you don't have to choose. You can go anywhere. So you have to decide using analytics, and this is where the health plan comes in. How do we help you decide who your patient is? So you have to come up with a model, and that's attribution to say, this patient has seen me 3 times, so we think this is my patient 3 times in a year. And then you create a model around those people. So it is a little different.
So will we ever get to the point where there isn't fee for service?
I don't have a crystal ball, but I can tell you that we will continue to support physicians in that evolution to try to evolve from fee for service to value, primarily, of course, for the triple aim.
Yeah. Are other Blue Crosses coming to you to figure out how to do this?
We're all doing it together. So I represent Blue Cross Blue Shield of Illinois, and that's about a little bit over almost 7.8 million. Maybe half of the members live here, but I'm really part of Healthcare Service Corporation. And Healthcare Service Corporation has 5 Blues plans, plus 9 other either wholly owned or partially owned subsidiaries. So our other states, Texas, Montana, New Mexico, and Oklahoma, all have value-based care models. So we're moving together collectively. We're over 15 million members. So we are trying to move the needle. And of course, we're part of the Blue Cross Association, and we work collaboratively to get best practice from other Blues plans.
When you make this switch, will prices be lower?
Prices?
My price, I'm a patient.
Oh, you mean the premium? I'm sorry. So will the premium be what you see for as a patient, where the premiums be lower?
Yeah, I'm a patient. Will it cost me less?
It's an actuarial answer that I can't give.
Okay.
Thank goodness. Thank goodness. Right, but that's the goal. So in other words, when you ask me about price and premium, and truly that's an actuarial decision around how we set our premiums, our rates. But I can tell you that the goal, and conceptually, if you look at the care models, and as a physician, if you look at what's being done by the doctors in those models, you would have to improve quality, right? And so you can't. That's probably number one. So I don't like to get back into about the cost, because you can't. Quality is probably first, and when you improve healthcare, you're going to see a spike sometime. You're going to, if people start receiving primary care and preventive services, you may see a spike somewhere in certain parts of it. So you may go up here or down there, but the goal is really the triple aim. So I hesitate to focus just on premium.
I hear you. Are doctors receptive to this change?
Extremely. And the doctors that are a part of the models have very positive comments so far. And again, my excitement right now is to look for how do I bring that to even more doctors, so that doctors in all types of practices can participate wherever they are in their evolution. So maybe they're not ready for an ACO, maybe they're ready for something else, but we want them to be able to be a part of whatever to help make that transition.
Other insurance companies doing this?
Yeah, but I try not to focus on them either.
Yeah, I don't blame you.
All right.
So Tom, tell us about housebound medical practice.
Right. And so, in the value-based, when you talk about cost savings, as I said, the goal of house calls is to help these homebound patients, to help their caregivers, who are the real heroes in this field. But it's the healthcare cost savings that have been, and when you look at the cost of our society, a lot of times you hear 5% consume about 50% of the cost at an average cost of $43,000 a patient. Well, the top 1% consumes 23% of total cost at an average cost of $98,000 per patient. And so that is where risk stratification is so important in terms of trying to develop cost savings. While by their very nature, house calls that tend to aggregate patients with 5 or more chronic diseases and multiple ADL deficiencies, by just their very nature, they risk stratify into taking care of these most costly patients. And because their only opportunity for health care before house calls was an ambulance trip for about $1,000 to an emergency room where statistically, because of their frailty, they have an increased risk of being admitted, it was just a very poor primary care system for these patients. And so there's all these things now in terms of demographics of our society. The most rapidly growing age group is the 85 years of age and older, which is quadrupling between 2000 and 2050. Half of them need assistance with at least one activity of daily living. This is an exploding homebound population. And so the goal of house calls is to keep them out of hospital and keep them out of nursing homes. And what is exciting for us is actually some data is finally coming out. There was two great journal, not JAGS, Journal of the American Geriatric Society journal in October. One was with the Veterans Administration. The person who runs all the geriatric programs for the Veterans Administration, his name is Dr. Tom Eads. And he was told in the mid-2000s to, well, I'll tell you about his program first. His program called Home-Based Primary Care, they were spending $11,000 more on their patients than usual care, just home care alone. And so what do you think Tom Eads was told by the VA to do with his home-based primary care program when he was spending $11,000 more per patient, okay? He was told to cut it. Well, they were kind enough to give him 6 months. A gentleman by the name of Dr. Bruce Kanosian looked at all the data on these patients. And what they found was a nursing home reduction of 89%. You know, not 50%, and that's a third of all Medicaid costs is nursing homes. So they reduced the VA nursing home days by 89%. They reduced hospitalization by 63%, reduced overall cost for patients by $9,092. And when you multiplied it by the 11,334 vets in the program, it came out to $103 million savings by giving these vets $11,000 more care in the home. You know, is it too wonderful? And then another study, and they actually redid it, and it was, what they actually redid in this JAGS article was they looked at, what they didn't do in 2002 was looked at, because vets can go to Medicare or VA, they weren't sure if it was cost saving. When they got sick, did they go to Medicare? And when they needed their medicines, did they go to the VA? And what they found in 2007 data was that there was, again, a 13.4% overall cost savings, 16.7% to the VA, but 10.8% to Medicare. So it actually, this great program actually saved both. There was another program, another study in that JAGS article, MedStar program, 722 house call patients, where again, they had a 17% cost savings for this most expensive population, saving $8,500 per patient. And again, by giving them, so they had more primary care visits, more home health visits, more hospice visits, more, and they saved $8,500 per patient because they had less ED visits and less hospitalization. And so healthcare reform also with readmission reduction is helping us. The hospital that supports me, Central Page Hospital, is one of 3 hospitals in Illinois who has never had a readmission penalty, and they give us credit for that. And so there's all these things that are happening that are kind of supporting. For what I've been doing for 20 years, all of a sudden I'm becoming kind of popular in this country because of this. But the last thing I'll say, and this is, I think, going to segue well into Dr. Orgain's information, is end-of-life care. And so, again, our average age patient is 80, a third are over 85, 8% are under 65, and they're, you know, they're all neuromuscular, cervical spine injuries, multiple sclerosis, Lou Gehrig's disease, traumatic brain injuries, all people that are bedbound or wheelchair-bound, younger, but the average age is 80, a third over 85, and about 20 to 25% pass away a year. My wife says you need to be careful saying that in terms of what kind of doctor you are, but I hope it has to do with the population and not the care they're receiving. But there was this great article by Tino looking at deaths in our country between 2000 and 2009 that was published in JAMA, and it starts out looking really good. The number of deaths at home went up by about 3% during that time to 33.5%. Deaths in hospital went down by about 8% from 33 to about 26%, and hospice deaths went up from 22 to 42%. Isn't that wonderful? Okay, and there's a big but. The number of hospitalizations in the last 3 months of life went up from 63 to 69%. Just think of that. What wonderful end-of-life care. 63 to 69% of people who die in this country on Medicare spend some time in the hospital. The number of people in the intensive care unit in the last month of life went up from 24 to 29%. 30% of our seniors spend some time in the ICU in the last month, and if that was the best end-of-life care, we'd have to, argue, but it's known not to be. If you want to suffer, if you want to be short of breath, if you want to be in pain, spend time in the intensive care unit at the end of life. And in contrast to that, our patients in 2013, we had 222 deaths, 80% were at home because we talk goals of care, goals of care, goals of care. Sometimes they threaten to haunt you if you let CPR be done to them. And so this is people, you have to talk about it, In fact, I just had someone on the North Shore where she's 96 years old, and I usually say in the next 10 years, between now and turning 106, there's a chance your heart might stop. And she goes, and she said, I hope so. And then I usually ask the next question, which is, goals of care. And she cut me off and she said, and if you do anything to stop that, So she, cut me off. And so, but you have to have these conversations in order to fulfill their goals of care. And again, we're going to hear more about this. But so, 80% died at home, 74% were on hospice. And most of them never stepped a day in the hospital the last year of life. Not only is what they want, but there is millions, if not billions of dollars of cost savings if we could do this for our society. And so that's a little about my life.
Most people would rather die at home than in a hospital.
Statistically, 70%. Robert Wood Johnson's study showed that when you ask people when they know their time is coming, where would they like to be, and usually when they say they don't want to be at home, it's not because of them, it's because of the concern over their family.
Giving them too much.
Yeah, being a burden on the family.
And are there a lot of deaths in nursing homes?
I don't know what in terms of the percentage in terms of hospital or nursing homes. Is anyone, I'm not sure where those, I know nationally 33.5% of patients die at home, but I don't know what the other 76.5% where the deaths are, how many are in the hospital, how many are in nursing home. But they are in institutions.
And what kind of equipment do you take when you visit the home?
Well, I'll show you, and so that's the thing, and so it was the equipment that technology, so 40% of all healthcare in 1930 occurred in the home, 10% in 1950, less than 0.5% in the 1990s. And it was technology that drove it to the office and the hospital. Well, now everyone knows technology, and so I'm just tapping an icon here. There's actually 2 leads on the back of my phone, and so in about 5 seconds, you can see if I'm nervous, if I'm tachycardic. But so, can you guys see? So here's my EKG on my phone, and so I have my Epic, my Epic EMR is on here. Most doctors who has Hippocrates on their phone, in here, no advertising. Should I not say that? But I mean, so it really is, so my EMR is on here. I can do EKGs on this. You can actually get things where you can get the pulse, just by putting your finger over the, and so it really is amazing where technology, I just did an x-ray on an abscess I'm going to drain today, this afternoon, of a quadriplegic patient on a ventilator at home, that I did an x-ray just to see if it showed any signs of osteomyelitis yesterday. Ultrasounds can be done in the home, any blood tests can be done in the home. And so it really is quality medicine, but most of the quality medicine is not that technology. I need that technology. It is quality primary care. It's talking to them, it's finding out their goals of care, and managing these multiple chronic illnesses.
How do you do an x-ray at somebody's home?
Well, here, actually in 1994, you guys can't see this, but this is me. We used to have an x-ray machine in a van, and this is 15 minutes later after my tech developed it in the x-ray. And that's why my wife supported me, because that company went bankrupt. And so, and it was great, but literally this was a patient, you guys can't see this, but and this is what's so sad. I was doing this in 94. She was not eating or drinking, 92 years old. She had 104.9 temperature. We did an x-ray, it showed pneumonia, and we did an I-stat, her potassium was 2.9, she was dehydrated, her BUN was 97 for those in the audience, started a 0.9 normal saline with 40 of potassium, hung a gram of Rocephin, and my doctor friend said, Tom, you're begging for a lawsuit. And there was 2 lawsuits in millions of house calls in the last century. People don't sue their house call doctor, And actually the last picture I'll just show you, you guys can't see it, but the last picture was her and this shocked me, at the breakfast table the next morning. You guys
Yeah,
can't
look how
see this,
healthy
but
she
she was
looks.
up at the
She
breakfast
looks
table
great,
because I went
yeah.
to walk to her room, and the daughter said, "Where are you going?" And I said, "Well, to see your mom." And she goes, "Well, she's at breakfast." And so, I mean, it's just, and so in 1994, I got paid $101 for that house call. I had to eat the antibiotic because Medicare does not cover antibiotics, you know, in the home. And so my biggest payment was I got a great feeling. But now with value-based medicine, if I can prevent an $8,000 hospitalization, there's actually a Medicare demo going on right now that actually Congress is voting on something possibly today that I'm very involved in, that where I could actually get $7,000 from cost savings to care for this patient at home. And that is where the system's going, is I will be paid for the value of keeping all these people at home.
That's very well.
So, thank you. Thank you.
So, Tom, you showed us the decline in the percentage of treatment at home from 40% to 0.5. Has it gone up since the 90s?
Actually, great point. So there was an article in New England Journal of Medicine, 1997, The Vanishing House Call, predicting the extinction. I've got a great joke of a house call doctor with a bag in a museum, you know, saying, you know. But actually, this is good for you to know. So house call payments, I'm actually president of the American Academy of Home Care Medicine because of our organizations. House call payments doubled in the late 1990s. You know, my most common payment's $130, you know, and it doesn't go very far, but it's better than what it was, you know, $59 in 1996. But so house call payments doubled. JAMA had an article in, I think, 1995 that showed a 43% increase in house calls in the early 2000s. And then we doubled and tripled assisted living payments in 2006. And the number of assisted living visits has gone up by 83%, overtaking house calls since 2006.
What does that mean, an assisted living?
Assisted living is like, I mean, I know names like Brookdale and Sunrise and Brighton Gardens,
yeah.
and so there's economies of scale there because you can go and
there are
see,
10 patients in one building.
or like 100 patients in one building,
I
right?
see.
And so payments have gone up. Chronic care management codes. Next year, we're trying to get advanced care planning, and so you can get paid for discussing quitting smoking. We're pretty certain that next year you're going to be able to get paid for discussing advanced directives with your patients. That's something that we're working on now.
Could you use your phone and just visit the person by video? Not even go?
You know, Philips has a neat model. They're doing this at Banner Care where they are doing virtual house calls, and I really think that is the future. You don't need to be there face-to-face. They even have these kind of robots that have stethoscopes and stuff and video, so you can see wounds and listen to their heart and lungs and stuff like that. So I really think with the primary care shortage that it's not going to replace all visits. And I'll even tell you, these goals of care conversation, they are so relational. But I really do think that that there is technology. FaceTime is not HIPAA compliant, and so there are programs that are HIPAA compliant video technology that you can actually talk with your home health nurses and your aides in the home.
Yes, sir.
How sick does a person have to be to make a house call meaningful?
So how sick do they have to be? You know, home health, they have to meet, there's a Medicare definition of homebound, where it has to take a taxing effort to leave the home. They actually specify in the regs you can get your hair done once a week, you can go to church once a week, but you have to pretty much be homebound. For doctors and nurse practitioners, whoever are doing these house calls, it requires medical necessity. So actually, my greatest impact in terms of case studies has actually been in younger mental health patients where they just keep going. One of them had 44 emergency department visits, 27 hospitalizations, half the intensive care unit in a year and a half. And we went out there, and again, through relations, through taking care of his diabetes and his mental illness, because he would never follow up with his primary care doctor, we literally got that down to one visit over the next year. And so it really, and a lot of times now hospitals, so the hospitals I'm working with in Chicago, Northwestern, Rush, U of C, UIC, a lot of them are asking for me to help them for having transitions of care models. And so if a patient is at high risk for readmission, the hope is to get him back in his suit to work, but for that temporary period after the hospital to try to reduce them from having to come back, which is both good for the patient as well as now good for the health system.
And you're able to see benefit for your behavioral health patients as well as your physical health?
So are we able to see, love, vitamin L, I call it, goes a long way, with these patients. Because really, you go to their home, you show them such care, But we are actually blessed to have a Metropolitan Family Service behavioral health social worker that does house calls to our patients. And what's really cool is my health system allowed them to go on this thing called Epic Care Link, which is an Epic read-only, where literally they have complete access to all my charts. We have optometrists that literally have taken people legally blind from cataracts and have been able to give them their eyesight back. And they're also on Epic Care Link. And so we're developing this community. We're trying to get the Area Agency on Aging actually on Epic Care Link. And so we're all kind of hooked into the same community electronic platform so we all can communicate and see the same record. So.
What happened to the house call? Why did it decline from 40% to 1%?
The main reason was initially really was technology, and then fear of liability. I call it fear of liability because we did this search in 2003, my academy, and again we found 2 lawsuits. And what was interesting, there was 2 lawsuits because the doctor didn't make a house call. But it really has been, finances. Even though it's doubled to $130, $130 for the time it takes. And so house calls do pay about $10 to $30 more than an office visit. But in terms of the travel time, and these patients are very complex, and so they're not quick. And so it really is dollars that, dollars is why we're here. If you funded primary care more, you'd see more primary care.
Yes, yeah.
Yeah,
exactly.
so.
Yeah.
Is there space for a physician who has office-based practice to incorporate house calls into their practice, or do they need
Okay.
to just really focus on?
So can you do house calls and office visits? Absolutely. In fact, the programs that I'm working with in Chicago, those tertiary care centers I talked to you about, all of them, John Hickner can let us know later what their plan is, but he has 6 doctors already. They're going to actually have to compete with one another to do house calls because they're not going to have the volume initially probably, but I think all of them are planning on maintaining a house call practice along with. When I started, I was actually an immediate care doctor. That's where I got my money. And then as the house calls got busier, I pulled away from that. But no, so you could definitely do both.
Thank you.
Thank you.
My family moved to London in 1997, and predictably, Willa Reed, my 12-year-old, had an earache about a week later, and we called the doctor at they call it a surgery, at the doctor's office. Could I bring my daughter in to see you for her ear infection? And the receptionist said, well, yeah, the doctor will be down there between 2 and 4. Down where? Well, your house. And I said, she's going to come to our house? And this woman said, oh, you're a Yank. You're American.
Yeah.
You don't get this.
Right. All primary care doctors in England do house calls because they
Yes.
know the value-based care, right?
Yes, ma'am.
Thank you. I just think it's important to note for those who aren't family physicians, as part of our training, we're required to do house calls and visits.
Right.
Oh, I didn't know that, really.
Right. 6 for family medicine, and actually UIC sends their residents out, and for one day they get 10, and the letters that they write back of thanks are just so heartwarming.
You're required by whom?
By the ACGME, our accrediting body requires us to do that. So it's part of our practice always.
Has this gotten to Colorado? It should be there. Okay.
Didn't you come out on a house call with me recently at Northwestern, or?
Me,
Yeah.
I'm a former resident from the University of Chicago. I work at Northwestern.
Oh, okay.
We did do 20 house calls.
Okay.
A lot of times the patients really appreciate it, and not many patients were aware that we are able to do those. So
Right.
just getting that information out there.
It's a big deal.
Okay. I thought you looked familiar.
Thank you, Tom. So one of the striking things here is, what did you call it, choice of care? The
Goals of care.
Goals of care.
Goals of care. Goals of care. Goals of care. What does a patient want?
And when the patient, I wonder if this happens, Javette, when you go to your patient for hospice care, do they know they're dying? I mean, is this clear yet?
That depends upon the family. Sometimes the patients, we as hospice providers want to ensure that the patient is aware of their condition, but oftentimes there are family dynamics, and sometimes the families ask us, please don't tell them what their diagnosis is. We cannot deny them the information. And so we approach the discussion with them very carefully in regards to the family dynamics, in regards to what their diagnosis is.
And what's hospice trying to do for these people?
Well, let me just take from what Dr. Cornwell said in regards to hospice. The modern hospice movement began in 1950s, and it began in Europe, as a matter of fact. And so as you talk about the healthcare industry in the United States, it began in Europe, and even to this day, it has grown in the last 3 years, but we still have concerns about the death and dying process in the United States and our ability to talk to families about their goals of care. So some of the diagnosis that we use in regards to hospice is no longer just cancer. It's also end-stage congestive heart failure, ALS, HIV/AIDS, multiple sclerosis. And so it's not simply just cancer in regards to the diagnosis that we see, end-stage liver disease. So we have, and when we talk about the triple aim, we have an interdisciplinary team, and I know that everybody's jealous. We meet every week with an interdisciplinary team. The kinds of things that we talk about in family medicine are we have myself as a team physician, the nursing staff, we have home health aides, chaplain, social services, we have the team manager. That interdisciplinary team takes the time to talk about all the patients who are within our care, to talk about the kinds of things that they will need to deal with their goals of care towards the end of life. Now, what we need for the change in culture in the United States is for, as Dr. Cornwell indicated, the patients to not continue to go in those last month, 2 and 3 months, to continue to go in and out of the hospital. In the Annals of Family Medicine, most recently, it talks about the fact that family medicine and comprehensive care, which from my perspective also includes hospice care, if we reduce the number of hospitalizations and as well as reduce the cost of care for those patients. And so it's very important to change the culture, to teach that while you're doing the home visits, to teach end-of-life care, to have those discussions with both the families and with the patient in regards to goals of care. So in addition to what Dr. Cornwell said in terms of home visits, we have inpatient hospice units, so that if the family is uncomfortable with the patient dying at home, but up until a particular point they want their loved one at home, we do have inpatient units. We do see, and so I'm part of that home care team in regards to doing that care, that hospice care in the home. And we have contract beds at other hospitals. VITAS, who I represent, is one of the largest in the nation, but there are 10,000 hospice organizations throughout the United States. We have quite a few in the area as well. So the hospice movement is increasing in terms of care in the home and, where necessary, care in a hospice inpatient unit.
There are hospice units in Chicago?
There are in Chicago, there are inpatient units, and in the future, there will be a dedicated outpatient facility for hospice patients, as well as that care in the home. And so we encourage the patient to be in a comfortable, loving environment, as Dr. Cornwell said, particularly to increase their quality of life at the end of life. Do no harm to the patient. And oftentimes, as you've seen recently, the amount of chemotherapy, the amount of invasive procedures, the chest tubes, the vents, in terms of our quality of life at the end of life. I think that, and I would have to ask all of you, have you made your goals of care at the end of life aware to your family? Those are some of the kinds of things that we must do so that we can decrease, and we must educate our non-family medicine colleagues in regards to how to care for patients at the end of life. Sometimes what we do in regards to chemotherapy and invasive procedures is more harmful to that care at the end of life.
Who calls you, Javette? The patient or the
As a matter of
son,
fact, as a matter of fact, oftentimes we have collaboration with that primary care physician, that family physician, who can participate in the care. I'm the team physician, but we can collaborate with that family physician or that primary care physician in terms of the end of life. And they call us, and unfortunately, sometimes it is that 1 month or 2 months before the patient is going to die. And we are encouraging you to enroll your family members or your patients into hospice before that 2 or 3 months so we can increase that quality of life. So the primary care provider will call us, the family sometimes as well.
What's the average time frame for treatment?
Unfortunately, it is 30 days or less. And there are very few who go beyond a year or 2 in terms of that care.
Yeah, I can see that. So probably in terms of dying with dignity would be better
Absolutely.
if they had more than 30 days.
Absolutely, absolutely, absolutely.
And who pays you?
Well, as a matter of fact, the majority of the benefit comes from Medicare, and Medicare prescribes the scope of services that can be provided. We provide a good bit of the same kind of services that Dr. Cornwell is speaking in regards to home care. So with our interdisciplinary team and the home health aide can go into the home from 1 to 4 to 5 to 7 times a week. The nursing staff goes in at least once a week. We will do subcutaneous IV therapy. We do respiratory therapy in the home. And so we have a number of services, the same kind of services that are provided in the home. Should the patient need additional services, we also provide the beds, the bedside commodes, the beds, and all of that kind of equipment that's necessary for the patient. Yes. Well, let me say that Vitas Hospice does in regards to seeing the need and adding that service and adding that information to what's provided. And yes, that is also a benefit that is provided for hospice patients.
You mean because somebody needs a hospital bed? Is that
Absolutely. Many of the patients will absolutely need a hospital bed, will need a bedside commode, will need that kind of medical equipment that will help them in that care in the home. Absolutely.
And why are the families uncomfortable about having somebody die at home?
One is because we have not dealt with, some of it can be religious beliefs, and so we've increased the number of religious organizations who are accepting of the whole discussion of death and dying and the care. Many people consider hospice as withdrawal of care. And we have to re-educate the community in regards to that is not withdrawal of care, that's actually providing more quality of care towards the end of life, recognizing that at some point the body cannot handle some of this extreme care, and that we are finite organisms. So.
How often do you get a patient under Medicare age?
Oh, you mean, yes. Well, the Medicare benefit in terms of hospice, you don't have to be 65 plus in regards to hospice
really?
benefit. If you have a terminal illness, you will still qualify. So you don't have to be 65 plus, you don't have to be 85, but if you have a life-limiting disease or terminal illness, you can qualify for the hospice benefit.
Opella, are insurers paying for these home visits?
You know, we do, and
You're into innovative, yeah.
we are, and as I listen to him, part of the reason why I always enjoy coming out, because I get inspired by more innovation. So,
Yes.
and think about how we can further integrate. And as I was listening to what he's offering, we have different relationships with, doctors to perform home visits, and it's really important. I've seen it work, very well in patients.
So I think if I'm the payer, I think a home visit would be cheaper.
Again,
Save me money?
How you use any service, and I'm really not trying to be coy about price.
No, that's fine.
I'm very serious about the fact that the clinicians need to make good decisions about the available resources. It may be a home visit. It may be, there are times when you make a decision as to where the care should be delivered. That's a really important piece of cost. So if you make a decision to care in the home and it's not well coordinated, and you don't have a physician who really is tuned into that and listening to the team, you could actually potentially spend more. It really goes back to the basics of you need a good doctor who is working with a team of people with good information. There is no fast way to do it. And I think that's part of where we're getting stopped a little bit in healthcare. We keep thinking that there's a way to do it besides collaborate, work with the family, work as a team, and then figure out what's best. And that's really the truth, because any tool
Oh,
that
that
you
way it
use,
seems so cumbersome is what
it
you're
is, yeah, because right, exactly, because
Yeah.
anything you do, you could inadvertently add cost if it's not used appropriately.
Yeah.
So we're all back to the responsibility of what's best. And that is not made by the insurance company. It's not even doctor-driven completely. It's everybody. It's you as the patient, it's the family, it's the circumstances that you're currently in, all help you determine what's the best care. So we always tie that with where's the best place, the best time, the right time, and that varies during the course of your life.
Yes, sir.
But your question, Mr. Reed, involved reimbursement.
Yeah.
And so both of our practicing physicians gave awesome accounts of what they do. The real issue is reimbursement. I don't think Tom is getting adequately reimbursed. So the family physician is always trained as an osteopathic physician at McNeil in family medicine, been practicing all these years, doing these very things, but yet our reimbursement isn't there. The average, salary for a family doctor is $195,000, which is just above the lowest at pediatricians.
Yes.
And female physicians is much less than that, by the way. So the real issue is we're not being recognized and reimbursed for the care that we give as well-trained family doctors. So I think that's the question that wasn't really adequately answered by, the doctor from Blue Cross Blue Shield.
Yeah, I wish I could be responsible for the reimbursement for the healthcare system solely. But since I'm not, I think my best contribution at this point in time, and with all honesty, I'm not. It's teachers there are lots of, that's a societal discussion around what we value and how we decide to spend our money as a society, right? So go ahead,
Yeah.
please.
So if I can add to that, what we always like to say is that it's not the reimbursement, it's actually payment for the work that you do. So if I can help us also reframe what we say and just please pay us for the work that we do and the quality of care that we get. And in addition, particularly for the hospice benefit, Medicare is considering some changes to that payment model in regards to what they do. Even as we speak, Medicare will be coming out with some changes in what they do in regards to paying hospice. And so what we ask is for advocacy, and we appreciate you all being here. So we need your advocacy in regards to that. So the American Academy of Family Physicians is working very hard at the national level in terms of changing those payment codes so that we can get paid for those services that are invisible to a lot of other people. That telephone call, that paperwork, that, we essentially oftentimes do a visit by phone. As Dr. Cornwell said, it hasn't been in the office for a while, that home visit. So we need your advocacy in regards to paying for those services. So, and thank you for that.
Okay, I think I've asked, I have 100 more questions, but I'd rather hear yours. So anybody here have questions? Yes, sir.
Okay. Well, thank you very much. These are really inspiring stories. While I hesitate to add to anything Dr. Orgain says, she forgot to mention that patients in hospice actually often live longer than similar patients who are actively treated.
Thank you. Absolutely. Thank you. That was a very important point.
What strikes me here is that we have a disconnect, though, between our vision and our infrastructure. As we all know, health systems, and none of them are blameless, have engaged in what I call the edifice complex, that we're building these huge gleaming institutions to do exactly the kind of thing you seek to avoid, which is expensive inpatient care. And I don't see that abating. So I'd be curious to hear the panel comment on how, as we shift from volume to value, what do we do about the infrastructure that's organized around volume?
Just personally, I'll tell you, I've gone viral in Chicago with these. I mean, seriously, we really, I just got these dollars, and we haven't even kind of created a product, and I'm just getting phone calls and meeting with the highest levels, 5 EPs at Rush, all chief medical officers at Northwestern, Dr. Hickner, the director of family medicine at UIC. And so, one thing in terms of the reimbursement, I have such hope at this meeting at the AGS and AHCM. Sean Kavanaugh, the head of CMS, came to my house call meeting. They're seeing the value of what we're doing, and these 3 other very high people from CMS, the AGS public policy meeting, really talked about they are so serious, and it is happening, that more and more dollars are going into value-based care, and that is what is good for us because we produce, value. So I think, both these, that I think, that the institutions are realizing that it is in their economic interest to keep people in community. And so they really are focusing on partnering, and you're going to hear that more in the next talk in terms of really neat partnerships that are developing between primary care and the community, which is beneficial to their health systems.
So let me add, if I may, the theme, one of our themes is health is primary. And we are, as physicians, we're educated primarily on individual health versus population health. And so in order to decrease the need for increase the need for value-based care versus volume, we also have to advocate for a healthier population in terms of what we do. And that's prevention. So we need to advocate for those social determinants of health that are not discussed in the realm that we'd like it to be. Stop tobacco, stop alcohol, do more exercise, have a healthy living environment. And so those are the kinds of things that we also need to discuss. And then maybe we'll have a healthier population that will reduce the need for such, that every 15-minute visit.
One of the things directionally is that, as you know, Secretary Burwell announced that, with very specific metrics, to move from fee-for-service to value from the Medicare payment system. And so one of the positives from that is the Learning Action Network, and that particular group of individuals are both payers, private sector, everybody coming together to sort of figure out how is this scalable and what do we do. So, it does require focus and scale in order for really to see it actually move the needle. But I think people are committed in a way, coupled, than they have not, previously been able to collectively move together before.
She's behind the pillar. She's been standing there a minute. You can't see her. Okay.
Hi, John Igner from UIC. I'd like to shift the conversation a little bit and talk about another challenge that we have, and that's the patient or the consumer challenge, and start with a little anecdote. I've practiced at a community health center on the south side of Chicago for a number of years, and one day I saw a patient who had been hospitalized at 4 different hospitals within the last 2 years, who was coming to me for her first visit after having been to several other doctors. It's not clear to me that a lot of our population understands the value of having a primary care physician or nurse practitioner, and how do we get people educated so they understand that, yes, it's a good thing to have a primary care physician or nurse practitioner or physician assistant?
Our initiative. Actually, that is one of the primary areas of focus of this Health is Primary, is to get, as I said in my introductory remarks, really all stakeholders, but probably and most especially patients, to understand the value to them personally of their health being better and their health care costs, which they at some point pay some portion of, their costs being lower, but their care being better. And you're right, we don't have that awareness in our general population, and that's where this Health is Primary initiative is going. My hope and my aspiration is that patients then, so understanding the need for that, are going to become a powerful grassroots voice to demand that type of healthcare system in this country.
Yes, sir.
So how did, kind of piggyback on what John said, how do the retail clinics and all of the Walgreens, CVS, and how do you kind of fit the presence of all these different operations into this model? And I'm looking to any of you to answer.
Yeah, I didn't know who you were looking to answer.
Because we see more and more, every day there's a new one opening. There's the outpatient clinics, the urgent care. I mean, just in my own block, there's 6 or 7 I could walk to.
Yeah.
I think it's, and this is where EMR is, because like CVS has Epic, and so, hopefully there is some, kind of, I don't know if they can see other doctors, but, I think it gets to, before the triple aim, the comment was right care at the right time in the right place, and I think that's because one of the questions for me is you really need to risk stratify these patients, because having a whole doctor team go to a patient who really doesn't need it is not a good use of resources. And so the question is, can they get into their doctor in a timely manner? And so I think that's kind of a difficult, question, because I really do believe what you're getting at is that primary care role. But part of the problem with the shortage of primary care doctors is we're all so busy, and if you call sick and you can't get in for 3 days, that's where I think there might be a role for these, programs that can handle, the less longitudinal acute problems and take care of them, same day at the time the patient wants it. That's consumerism, at work.
Since that train is out of the station and we know that they are here to stay in terms of retail clinics, then what is incumbent upon family physicians is to establish a relationship such that, with your patient as well as with the organization, such that when they go, then that follow-up is with you. And you have a relationship such you know, and they will communicate. Oftentimes that's not the case, but we need to advocate to ensure that when the patient goes into that retail clinic, they follow up with you in terms of that continuity and comprehensive care. As Dr. Cornwell said, the reason why they are burgeoning is because the consumers say that this is what they want. I want what I want when I want it, on a 24-hour basis based on the lifestyle. And so we have to become available to our patients when they need it. And we want to ensure that we are happy in terms of what we do, and we know that we have our own lives, but we also have to ensure that the patients are being served.
To the conversation previously about end-of-life care. I work at North Shore University Health System. We have a program for palliative care. Can you talk a little bit about what this group is doing in that area to advance palliative care and what the role is of the primary care in that conversation with the patient?
When you say this group, what do you mean? Oh, the health is primary. The health is primary. Well, that's why we're here today, to talk about home visits and for me to talk about end-of-life care. I think that part of what we were doing, there wasn't necessarily the visibility of the fact that we as family physicians and primary care physicians take care of families from the beginning throughout the life spectrum. And so when you ask the question, how are we advancing that information and moving towards encouraging more of that discussion to occur at the educational level, we are continuing to establish those relationships so that students and residents can work with us and have the electives until such time as that can be thoroughly incorporated into the academic environment. And so yes, we have the American Geriatric Society, we have fellowships in hospice palliative medicine. So there are organizations that are trying to, in addition to the hospice organizations, that are trying to make sure that end-of-life care is also part of the total care in regards to the patient. And educating oncologists and other specialists who will see more of those patients, particularly cancer patients. Consider hospice before you consider all of those treatments that you know that may not extend and may also do harm. So we're working on that. Did that answer your question? All right, thank you.
So if I could just add a little bit from the project standpoint, as I mentioned, we're really committed to a patient-centric healthcare system, and meeting end-of-life needs is certainly a big part of that. And in conjunction with this educational and communication effort is the strategic effort to bring together groups. As I said, family medicine certainly does not think they can do this on their own. There's a strategic effort about who else needs to be engaged in the discussion about building that ideal healthcare system? And certainly folks representing geriatric home care, hospice care are part of those organizations that Family Medicine for America's Health wants to reach out to have those collaborative discussions and say, how do we work together to advocate for that healthcare system?
Jim Valek from Little Company Mary Hospital on Chicago's South Side. I don't know if everyone noticed Dr. Cornwell's spiritual moment when he went into himself and he said, goals of care, goals of care, goals of care. I mean, it really was. It was an emotional, spiritual moment. It was wonderful. And I share that. And the revelation I had from that was we, as family physicians, have asked America's public and America's health leaders, what are your goals of care? And what are they? Lower cost, better health,
Great point.
better health outcomes. So we know what the goals of care are. Now we need to advocate for them.
Great point.